Today's lab is on the respiratory system, on both the anatomy and physiology of respiration. Remember that anatomy means structure, physiology means function. This first slide is a little unusual looking, I guess, but it shows you both a coronal and a sagittal view of the head through the sinuses and through the nasal cavity as well. These are called paranasal sinuses, which means surrounding the nose, but don't let that concern you. They're just the sinuses that we normally think of when we think of the sinus headache and the allergies and that kind of thing. For the left hand, the coronal view, you'll refer to slide 3 for the legend, which also shows a CT or a CAT scan image of the same part of the anatomy. For the sagittal view on your right, you'll refer to slide 4 for the legend, as well as the corresponding MRI image of that region. So if you look at the left-hand picture, the one through the made by a coronal section, look at number 1. Number 1 is part of the ethmoid bone called the crista galli. I'm trying to get you oriented to the slide. That's basically it. Number 2, you can see on either side of the crista galli you have the little yellow structures. Those are called the olfactory tracts inside the brain, and those are what carry the little olfactory or impulses of smell from the nasal mucosa up to the brain. Number 3 is showing what we call the middle nasal concha. Number 4 shows an opening of one of the sinuses, maxillary sinus, into the nasal cavity. Number 5 is pointing to the maxillary sinus. Number 6 is pointing to the inferior nasal conchae. Number 7 to the perpendicular plate of the ethmoid, which forms most of the nasal septum. And I think number 8, I would say it's pointing to the vomer bone. It could be pointing to the palate. I'm not sure, the hard palate. On the right, the sagittal section. Number 9 is demonstrating the frontal sinuses in the frontal bone. Number 2, again, the optic tracts. You can see the little sort of wavy looking lines that are coming up towards the optic tracts, which makes it almost look like a toothbrush. You can see that's a little bristle looking things. Those are actually olfactory nerves coming out of that nasal mucosa up to the olfactory bulb, or olfactory tract, excuse me. Number 10 is indicating the pituitary gland, with number 11 being the sphenoidal sinus. Number 3 is pointing to the superior nasal concha. 14 is the middle nasal concha, and number 6 is the inferior nasal concha. Number 12 is pointing to the the nasopharynx in the region of the adenoids or pharyngeal tonsils. 13 is showing where the eustachian tubes or auditory tubes open into the nasopharynx. So basically I've just told you what you're looking at on the previous slide, and then this is the MRI of the next one, the sagittal view that was on the right. Notice that the MRI is showing us a little bit more than what the sagittal section through the sinuses showed us. For one thing, you can see the spinal column and the spinal cord. The column is number 6, the spinal cord is number 7. That's some interesting anatomy. It just helps you to get your bearings if you look at some structures that you can easily recognize. Number 5 would be the tongue. Number 1 is listed as the nasal cavity, and it is. It's the very lower part of it. Number 2 would be the nasopharynx, and number 3 is listed on here just as the pharynx, although the pharynx, the throat, basically, there are 3 parts to the pharynx, which we're going to see on the next slide or two. But I believe this slide for pharynx, it's actually meaning the oropharynx, the region of the throat behind the mouth. Number 4 is the larynx, or the voice box. As I said, number 5 is the tongue. We've looked at the spinal column and cord. Look at number 8. That's the epiglottis. It's a very good view of the epiglottis, which is a cartilage that folds down over the opening of the that leads to the trachea during swallowing. So when you swallow, you don't want the food to go down the wrong way, so to speak. You want it to go down the esophagus in the back, so the epiglottis closes off the more forward placed trachea. Number 9 is another cartilage of the larynx. It's called the cricoid cartilage, and basically it's showing you the posterior part of the cricoid cartilage. Number 10 is a structure called the cricotracheal membrane, with number 11 being the trachea. I mentioned the 3 pairs of tonsils a moment ago. If you'll notice the 3 names, the pharyngeal tonsils, palatine tonsils, and lingual tonsils. Pharyngeal is an adjective meaning pertaining to the pharynx, and the word pharynx itself means the throat. So you may not have known that the throat actually has 3 portions. What we call our throat normally is called the oropharynx. If you look at the middle term with the bullet point called palatine or palatine tonsils, it tells you that they're located in the anterior part of the oropharynx. The oropharynx is the part of the throat behind the mouth. It contains the tonsils, or called specifically the palatine tonsils, and you know what the tonsils are. You can look in the mirror, open your mouth. You can see on either side of the back of the throat you have the tonsils there, with a little finger-like structure hanging down in between called the uvula. The uvula is part of the soft palate. So going upward from the oropharynx, you'd be in the nasopharynx, which is the upper part of the throat, or the pharynx. In that region, in that region are the pharyngeal tonsils, called the adenoids routinely. If you look below the oropharynx, there would be another region of the throat called the laryngopharynx, in which the lingual tonsils are located. The lingual tonsils are actually on the posterior part of the tongue. You'll notice at the top of the slide it says all 3 pairs of tonsils serve a lymphatic function, which means that they prevent bacteria and any other debris that are in the food that you eat and the air that you breathe from entering the bloodstream. I need to say, obviously, that these tonsils are not 100% effective in preventing bacteria and debris from getting into the bloodstream, but it is a first step, and there are several other regions that will also help to prevent infections from getting into the blood. So now the parts of the pharynx, or the throat. The superior part is the nasopharynx. The nasopharynx receives mucus that drains down from the middle ear cavity through the eustachian tubes and into the nasopharynx. The eustachian tubes are also called the adenoids, the auditory tubes. The eustachian tubes are located very close to the adenoids, and therefore if the adenoids are swollen up, the eustachian tubes will close up and mucus can't drain adequately then down into the back of the throat. The problem is that then pressure builds up back behind the eardrum. It can cause severe pain. It can cause infection. So anyway, that's something that some of you and I have had, unfortunately. The nasopharynx closes off when you swallow to keep food from going up into the nasopharynx as well as into the nasal cavity. So when you swallow, you want the food to go downward, obviously downward, but also you want it to go into the right structure when it goes downward. That's what the epiglottis was for. To keep the food from going upward, then you have the uvula. To keep it from going into the trachea, you have the epiglottis. The middle part of the throat, the oropharynx, is what you and I normally would refer to when we talk about the throat 99% of the time. Notice that the oropharynx is a common pathway for air and food. Hopefully not at the same time, however. Alright, I want you to think about something. Think about breathing in through your nose and or your mouth. Air travels in. It has to go through the oropharynx to get down to the larynx and the trachea. Think about taking a bite of food. You take a bite, the food goes from the oral cavity into the oropharynx to get down to the esophagus. So that proves then, or that demonstrates, that air and food are both in the same region, but not at the same time. If air and food do tend to get mixed up at the same time, in other words, if you're taking a bite and for some reason you accidentally inhale, then you could, get particulate matter, the food, down into the lower respiratory tract, which would result in a lot of discomfort, coughing, and possibly something more serious than that. The laryngopharynx is the lowest part of the throat, or the pharynx. It's below the oropharynx, or inferior to it, and it's superior and posterior to the larynx. Now, without a good picture, this may not make a lot of sense to you, but if you think about the region just below the oropharynx, where you can't see, you open your mouth, you can see the oropharynx. Below that is the laryngopharynx. The laryngopharynx is like a little vestibule that's going to lead to two places: the larynx, the larynx in front and the esophagus behind. So the larynx is the voice box. It is considered the gateway to the trachea. The voice box contains the vocal cords for the production of speech. But it's also very important for breathing because, as I said, it's the gateway to the trachea. The air has to go through the larynx to get down to the lungs, and it has to come back through the larynx to get out of the lungs. The larynx is almost like a cartilage box, if you want to know the truth, especially the front and the sides of it. The larynx consists of, obviously, there's smooth muscle, there's epithelium, connective tissue, but there are also lots of cartilages there that make up a good bit of the larynx. There are 3 unpaired cartilages, meaning that you have one of each, and then there are 3 pairs of paired cartilages, for a total of 9 cartilages of the larynx. You don't have to know the paired cartilages, but I would like you to know the unpaired cartilages. The first one listed is the epiglottis, or the epiglottic cartilage. This is a leaf-shaped structure. We saw it on a previous slide on the CAT scan. It covers the glottis, or the opening to the larynx during swallowing to keep food out of the airway. So that's a very important one, and I know this is redundant. The thyroid cartilage makes up most of the front and side walls of the larynx, but it doesn't go all the way around to the back. It extends about 3/4 of the way around the extent of the larynx. The upper part of this cartilage is called the Adam's apple. Below the thyroid cartilage is a ring of cartilage that actually does go all the way around the larynx. It's called the cricoid cartilage. The trachea is from 10 to 12 inches long. It's in the anterior neck, the front part, and in the upper mediastinum. Mediastinum being the region between the lungs. The trachea divides at about the level of T4, the 4th thoracic vertebra, and it divides at a point called the bifurcation. The word bifurcation means area where a tubular organ divides into 2 parts, because bi means 2. The trachea is reinforced by cartilaginous rings from 16 to 20 that encircle it for about 3/4 the way around. The back part of the trachea doesn't have cartilage in that region. The reason we have the cartilaginous rings is that they reinforce the trachea and they keep it from collapsing during ventilation. Ventilation means breathing. I like to think of the trachea as being similar to a dryer vent hose. If you know what I'm talking about, it's the air that, the large hose that air goes through to get out of the dryer, and it's vented to the outside of the house. You'll notice that that large plastic tube has a metal sort of reinforcement, kind of a spiral-shaped metal set of rings, I guess you could say, that keep it from collapsing as air goes through it. You see, it turns out that if you have a tubular structure with moist walls, and if air rushes through this structure, it would tend to collapse that tube. Think about the trachea. If the trachea had no cartilaginous rings and air rushed through it, it would tend to pull the walls together, the walls of the trachea together, and then you wouldn't be able to breathe. So the tracheal rings are very important in that way. For the dryer hose, the same thing. The metal rings prevent that from happening, to keep your house from burning down, basically. The inner lining of the trachea is of epithelium, the particular type called pseudostratified ciliated columnar epithelium. The operative word here is ciliated. These cells have cilia on their surfaces. And you may have had this in a previous class, but cilia are little tiny hair-like structures that move. They move a strand of mucus along the surface of particular types of cells. And the reason we have this in the trachea, as well as some other parts of the respiratory tract, is that they propel a strand of mucus upward towards the back of the throat, such that if the air that we breathe in is dirty, if it has particulate matter in it or what have you, this matter will tend to get trapped in the mucus. Then the cilia will move that mucus up out of the lower airway towards the throat to make sure that it doesn't get into the airway. Then when the matter ends up in the throat, then that's when you occasionally swallow, and this mucus then goes down into the stomach. These two images may be a little bit difficult to interpret for you, but if you look at the left-hand side, it says mucosal surface of the trachea. And now what we're doing is, if you look at the left upper part of this slide, it's sort of a light blue area. That is what we call the lumen of the trachea. I'm not sure why the word lumen is written down at the bottom of this slide. It's a little bit hard for me to figure that out right at the moment. But the lumen is actually where the little light blue color is. Number 1 is pointing to the mucus strand. You can really barely see it there. But if you look at number 2 is easily seen. Those are the little cilia on the surfaces of the cells that are lining your trachea. So see, this trachea is lying down, basically. I'd say about the upper half, a little bit less than half of this lying down trachea, where you have the large dark spheres, those are cells. Those are the pseudostratified ciliated columnar epithelial cells. Those rounded structures are the nuclei. And so I believe then that number 3 would be, that is pointing to one of those pseudostratified ciliated cells, with number 4 pointing to a nucleus of one of those cells. Number 5 is pointing to what we call a goblet cell or mucus cell. Now, if you look below that little row of cells there that are labeled 3, 4, and 5, if you look at the little border below them, it's labeled number 6. This is something called the basement membrane, and it's just a non-living connective tissue type structure that underlies all epithelial cells. Number 7 then is lying below, I guess you could say, or inside from the epithelial lining. And what number 7 is showing is called a chondrocyte, which is a cartilage cell that's lying inside its little bitty house. I guess you could call it a house, called a lacuna. To the left of there, you can see several spherical shaped structures. That represents cartilage. That's hyaline cartilage that you're looking at. So I realize that that image is not the easiest to interpret. The image on your right, the one that has the labels 1, 2, and 3, this is not the same thing that you're looking at on the left. Well, I guess you could say that it is, that the left is a much magnified region taken from the right-hand side. But basically, on the right-hand side, we're looking at sagittal, or basically parasagittal section of the trachea. So we need to get oriented to what we're looking at. Notice on your right of the right-hand image, you have the word anterior, and then to the left of that image, you have the word posterior. So we're looking at a longitudinal section of the trachea. It's cut slightly to one side of the midline. That's called parasagittal. To your right is the front aspect of that trachea. To your left is the back or posterior part. If you look at number 2, we have 3 structures, one after the other, lined up there, labeled 2. That is a cross-section of 3 of the cartilaginous rings of that trachea. Number 3, if you look at that arrow is going between 2 of the cartilaginous rings into the inside of the trachea that we call the lumen, L-U-M-E-N. The lumen of a tubular organ is the inside cavity. If you look at number 1, number 1 is pointing to 2 regions there that are showing the cartilaginous rings on the posterior aspect of that trachea. Now, it's important for you to note that this is a parasagittal section, meaning it's to one side or the other of the midline. If this longitudinal section had been made right down the center, you wouldn't see any tracheal rings in the posterior part of that trachea. But because it's cut to one side, you're picking up the regions just where the tracheal rings are just about to terminate there, because they've made their excursion all the way around from the front to about 3/4 of the way around. This slide just shows you the labels for the previous slide. Now, the bronchial tree. The trachea, as I said, bifurcates or splits to form 2 tubes, each of which are called bronchi. The first split or bifurcation forms what we call the primary bronchi. It means it's the first division. You have 1 primary bronchus per lung. Each primary bronchus divides to form secondary bronchi. The lung on the right has 3 secondary bronchi. The left lung has 2. Each of the secondary bronchi further divide to form the tertiary or third degree bronchi. It's the third division. You have 1 tertiary bronchus for every bronchopulmonary segment, which is about 8 tertiary bronchi for every secondary bronchus. The tertiary bronchi will further divide and divide again and divide again, but ultimately the bronchi will give way to the bronchioles, which are little tiny tubes that do not have cartilage in the walls but are rich in smooth muscle. And the bronchioles lead down to the alveoli, which are the air sacs. The bronchial tree is a term then for the trachea, the bronchi, as well as the bronchioles, and it's called that because it looks like an upside down tree. Note that the walls of bronchi contain cartilage, but the bronchioles do not. The function of the cartilages in the bronchi is the same as the function of the cartilaginous rings of the trachea, and that is to prevent collapse of the bronchi during the breathing process. This picture shows the lower respiratory tract, the bronchi, the bronchial tree, and the lungs, although it does still show the larynx and trachea. But it has everything on one picture, which is good. So notice the larynx there. But above the larynx, you have a little horseshoe-shaped bone called the hyoid bone. It's not labeled, though. Notice the thyroid cartilage and the cricoid cartilage. The epiglottic cartilage, or epiglottis, doesn't show up well in this projection. Notice the trachea, and then look at the bifurcation of the trachea where it divides into two. And then you've got labeled the primary, secondary, and tertiary bronchi. You have bronchioles labeled. Notice that the right lung has three divisions, or three parts, called lobes, L-O-B-E-S. They're not labeled, however, but you have the right upper lobe, the right middle lobe, the right lower lobe. The left lung has only two lobes, the left upper lobe and the left lower lobe. Notice that the left lung has a feature called the cardiac notch. It's an indentation where the left border of the heart presses into the substance of the lung on that side. Now you have an inset that is taken from the lung and magnified greatly, and that's what we're looking at in the box. That box shows that box shows alveoli, which are the little air sacs. Alveoli is the plural for alveolus, which is an air sac. The alveoli have an alveolar duct leading down to them that transports the air down to the alveoli. Notice that each alveolus is richly supplied with capillaries. The capillaries connect the branch of the pulmonary artery with the branch of the pulmonary vein. So it's across the walls of the alveoli and the capillaries that you're going to have oxygen and carbon dioxide being exchanged between the air in the lung and the capillaries. This is another picture of trachea and bronchi. It's the distal or inferior trachea. It shows the primary, secondary, and tertiary bronchi. On the right, or on the individual's right, it's in anatomical position, as you know. You have some peculiar looking little structures, little pink and purple and yellow and blue and so forth. All that is to show is that there was another picture on this slide that had the bronchopulmonary segments color-coded to show which tertiary bronchus was leading to each segment, but I didn't feel that was necessary to include. Now we're going to talk a little bit about physiology. We've looked at some anatomy of the respiratory tract. One moment, please. In these two pictures, we're looking at the thorax. On the left, you have inhalation or breathing in. On the right, you have exhalation or breathing out. In the pinkish, light reddish color, you have the lungs as well as the airway, the trachea. Notice that you have ribs, you have vertebrae, and finally look at the diaphragm. The diaphragm is the little curved, inverted U-shaped structure that's in brown. Alright, now in order for the inhalation to occur, The pressure inside the chest, the thoracic cavity, has to decrease below what the pressure is in the atmosphere. If the pressure inside the thorax remained the same as it is outside, then nothing would happen. There wouldn't be any air moving in or out. So in order to generate this negative pressure, the diaphragm is going to move downward, and you see the arrow there on the left. This is going to expand the volume of the thoracic cavity. Also, the rib cage moves slightly upward and outward, which is going to further increase the volume of the thoracic cavity. When that happens, it's going to decrease the pressure inside. The pressure drops below what atmospheric pressure is, so air is going to go from a higher pressure to a lower pressure, and it's going to fill the lungs. Now, when exhalation occurs, the diaphragm is going to move upward. This is going to decrease the volume of the thoracic cavity. The rib cage also will move inward and downward slightly, further decreasing the volume of the thoracic cavity. This is going to cause air to be pushed out of the lungs and out into the room or into the atmosphere, because the pressure inside the thoracic cavity now is going to be greater than what it is out in the room or the atmosphere. This is another picture that shows the external and internal intercostal muscles. The word intercostal means between the ribs. Costa is rib. On the left you have the external intercostal muscles. These muscles are falsely colored, but in the light yellow or manila color you have the bones. The light turquoise blue illustrates cartilage, and then in the red you have intercostal muscles. To your right, in the black box, but to your right, you have the terms 1st through 11th, and this is labeling the intercostal spaces there. So in each intercostal space you have the intercostal muscles. On the left you have external intercostals. These are the muscles that when you're about to breathe in, they're going to contract, bringing the ribs upward and outward slightly, and as I said on the previous slide, increasing the volume slightly such that air will rush into the thoracic cavity. To see the internal intercostal muscles, or at least in this particular image, we are looking at the back side of the anterior wall of the thorax. So imagine on your right now where it says internal intercostal muscles, imagine that you're looking at this individual from the back so that your right is on the individual's right. But they've been cut in a coronal or frontal section such that most of their ribs and all of the back part of that individual is gone. So you're just looking at the posterior area of the anterior chest wall, or the back of the front of the chest wall. The sternum or breastbone can be seen running right down through a good bit of the middle of this picture, and then you can see the ribs in sort of the tan color, and the muscles are in the reddish brown color. Now that we're oriented, the reddish brown muscles can be seen between the ribs. These are intercostal muscles, but they are on the inside, meaning they're internal intercostal muscles. The internal intercostals, when they contract, they are actually going to decrease the volume of the thoracic cavity. They're going to pull the ribs inward and downward. This is going to help with expiration, but they are only operative, or they only contract when the person is performing what we call a forced expiration. The accessory respiratory muscles are muscles that will assist the diaphragm and the muscles we just looked at previously with respiration, and they're only operating when forced or labored inspiration, expiration is taking place. The pectoralis minor muscles and the sternocleidomastoid muscles, when they contract, they're going to lift the ribs and sternum up just a little bit more and outward just a little bit more than what the external intercostals were able to achieve, meaning that when you force air in, the volume of the thoracic cavity is going to have to get slightly larger than it would otherwise, as accomplished by those two muscles. So they're accessory inspiratory muscles. The rectus abdominis muscles and external oblique muscles are accessory muscles of expiration, and they are only operative when the person is breathing out forcefully. So this would be if a person's been exercising or running, or perhaps they're under a lot of stress and they're having a more labored breathing. To breathe out more air than normal, those two abdominal muscles would operate in that case. This is another picture that shows these some of these accessory respiratory muscles. This is a microscopic view of a portion of a lung. We're looking at just a small portion of an alveolus, an air sac. This is to your left and slightly the upper part of the box. On the right and the lower part of the box is the inside of a capillary. You'll notice the most noticeable thing about this slide is the red arrow and the blue arrow. Notice that the two arrows are traversing a membrane, and that membrane is called the respiratory membrane. Look to the left between the alveolus and the capillary. That part of the respiratory membrane on the left is the wall of an alveolus. The part to the right is the wall of the capillary. So you have oxygen and carbon dioxide that are going to move across the wall of the alveolus and the wall of the capillary to function in gaseous exchange between the lung and the bloodstream. In the red area, you have oxygen diffusing from the alveolus into the bloodstream and into that little donut-shaped structure, the red blood cell. Notice we have a number in the alveolus, 104 millimeters of mercury for oxygen pressure, and we have 40 millimeters of mercury on the other side of that arrow, the red arrow. The driving force for diffusion then of the oxygen is the fact that the pressure of oxygen in the alveolus is much higher than it is in the capillary blood and in the red blood cell, because 104 is larger than 40, a lot larger. So oxygen is going to move from a higher pressure to a lower pressure into the blood. Carbon dioxide is going to be moving the opposite direction, and it is represented by the blue arrow. Notice the numbers for CO2 are at the beginning of the arrow on your right. It says 45 millimeters of mercury. On the other side of the respiratory membrane, we have 40 millimeters of mercury. This means that the pressure of carbon dioxide in the capillary is 45 millimeters of mercury. In the alveolus, it's 40. 45 is higher than 40. So oxygen is going to be moving from that higher, I said oxygen, I mean carbon dioxide will be moving from that higher pressure of 45 to the lower pressure of 40 millimeters of mercury in the alveolus. There's nothing magic about this. It sounds confusing, but if you think about why does blood go to the lungs, then all of this makes sense. So why does blood go to the lungs? It goes to pick up fresh oxygen and give off carbon dioxide. In order to pick up oxygen, the blood is going to pick up oxygen. This means that oxygen is going to have to come out of the lung into the blood, out of the alveolus into the blood. To get rid of carbon dioxide, that gas will have to come out of the blood and go into the lung, the alveolus is part of the lung, so you can see what's taking place there. So I hope you see that if you just don't get baffled by the terms and the numbers and the pressures and just think logically about what's going on, it really makes sense. You know that air, any gas rather, is going to go from a higher pressure of that gas to a lower pressure. This was happening when air moved out of the atmosphere into the lungs and back out again, back out into the atmosphere, and it's happening between the alveolus and the blood. In the lecture, I talked about a problem called a pneumothorax. A pneumothorax is a collapsed lung, and in this picture we see what would be equal to probably about a 100% collapse of that left lung. Pneumothorax, the term pneumo means air, thorax of course means chest, so it literally means air in the chest. I remember when I first learned of pneumothorax, the term pneumothorax, and I was confused because I thought, well, air is supposed to be in the chest, so what's the big deal? But look at the picture carefully. You see that air on the left-hand side, air is not in that lung anymore. The left upper lobe, LUL, left lower lobe, LLL, are totally collapsed. There's no air inside there at all. It's just lung tissue. It's alveolar wall stacked upon alveolar wall. There's air out in the pleural space or pleural cavity, however. That air is between the parietal pleura and the visceral pleura. That air is not supposed to be there. The air entered the pleural cavity through a penetrating chest wound. And if you look at the heavier red arrow, it shows air coming through a chest wound from the outside of the body to the inside of the thorax. But that air is on the wrong side of that lung. It's surrounding the lung instead of being on the inside of the lung. When that happens, the lung itself cannot expand anymore because the air inside the pleural space is impinging on it from the outside. So this individual would be extremely short of breath in this instance. To treat a pneumothorax, a chest tube has to be put in. You may have known someone who was perhaps in a fight, like they had been stabbed, or maybe they were shot, perhaps they were in a car wreck or what have you, in which they had a chest wound and air was able to get into the pleural space. And then a tube has to be placed, the chest tube, to gently and over time let that air come back out again and let the lung slowly expand. These lungs have different problems. On your left is a normal lung, but in the middle, this shows a lung that is being consumed by lung cancer, and on the right is emphysema. I'd like to talk to you about the lung on the right for a moment. If you look at the lower part of that lung, on your left, I'm looking on the extreme right, but on the left of that panel, you see two kind of swollen up regions that are black at the top and then reddish, and then on the right there's a larger one that's kind of longer and vertically oriented that's reddish. Those are called bullae, B-U-L-L-A-E, or they're also called cysts. There's several names for them. But here's what's going on there. Instead of the normal alveolar structure being present in those parts of the lung, the walls of alveoli have broken down, and instead of a few million air sacs being present, you have a few really large air sacs present there. And what happens is you don't have as much surface area for gaseous exchange. Think about all of the little alveoli and all of the capillaries covering the walls of each alveolus. Now you just have bigger compartments, and you're not going to have nearly as much surface area to allow oxygen to get in to the blood and carbon dioxide to come back out again. If you recall what the first slide looked like, the the title slide, that was a drawing of a lung that at autopsy, in which that person had had emphysema, and you see a large cavitation or an opening in the upper part of that lung. That's one of those bullae where, in actual fact, though, that was a bulla resulting from tuberculosis and not emphysema, excuse me, but it's a similar type of anatomical lesion there. Now to talk about some more physiology. There are different ways that problems with the lungs can be determined or diagnosed. Certainly chest x-rays, CAT scans, different types of tests like that can be done. But in terms of pulmonary function, one type of test is actually called a pulmonary function test. And in this type of test, they determine how well the lungs take up air and release air, and how well they move oxygen from the atmosphere into the body's circulation. The instrument used to perform these tests is called a spirometer. The process is called spirometry. Spirometry measures the airflow. The spirometer records the amount of air breathed in and out and the rate at which the air is breathed in and out over a period of time. For some of the tests, the individual breathes normally and quietly, while other tests require forced inhalations and exhalations after a deep breath. The purpose of pulmonary function tests is to diagnose certain kinds of diseases of the lungs, such as asthma, bronchitis, and emphysema. Pulmonary function tests can be used to determine the cause of shortness of breath, to measure whether workplace or other exposure to chemicals has affected the lungs, to check out the lung function before someone goes to surgery, and to check the progress of medical management of certain pulmonary diseases. Abnormal results usually mean that a person does have a chest or a lung disease. Obstructive lung disorders can make the lungs contain too much air and can cause the lungs to empty more slowly or abnormally too slow. These include emphysema, asthma, chronic bronchitis, and certain infections. It's interesting that obstructive lung disorders are problems of not being able to exhale, not what you might have thought. You might have thought that it was getting air in that was the problem, but in obstructive lung disorders, the real problem is getting the air out again. So what happens when the air is retained in the lungs too long is that carbon dioxide is going to keep coming out of the blood back into the lung, and carbon dioxide is going to build up in that lung, and it's going to build up in the blood, and this causes a lot of respiratory problems. In other lung diseases, the lungs are smaller than normal, and they're scarred, and they can't exchange gases normally, and they also contain too little air to be able to supply enough oxygen for the tissues. Examples of these include extreme overweight, pulmonary fibrosis, lung cancer, and certain connective tissue diseases such as sarcoidosis and scleroderma. Muscular weakness can also cause abnormal lung results. Pulmonary function test values vary based upon one's age, height, ethnicity, and gender. Some of the measurements obtained during spirometry are listed on the next two slides. We have certain entities called respiratory volumes and capacities. The tidal volume is the amount of air moved into and out of the lungs with a normal breath. In the average adult, this is equal to 500 milliliters of air. Notice that the tidal volume, it's equal to the amount of air breathed in during a normal breath and it's equal to the amount of air moved out with a normal breath, but it's not both of them added together. Because if you're breathing normally, the same volume, the volume you breathe in will be the same as the volume you breathe out. So 500 milliliters in, 500 out. To put this in perspective, for you to visualize about how much or how big 500 milliliters is, think about a 2-liter drink. Think of 1/4 of the 2-liter drink. That would be 500 milliliters. So it's probably not nearly as much air as you might have thought that is exchanged in and out during a normal breath. The inspiratory reserve volume will also be determined in the spirometry or pulmonary function tests. This is the maximum amount of air that you can breathe in after you've breathed in the tidal volume. So imagine breathing normally, and then it's a little difficult. You have to practice doing this. But imagine breathing normally and then taking in the normal inspiration, but instead of breathing out again, you're going to continue to breathe in just as much as you can. This is called the inspiratory reserve volume. Expiratory reserve volume is sort of the opposite of the former. That's the maximum amount of air that one can breathe out after he or she has breathed out the tidal volume. So you breathe normally, then you breathe out the normal breath, and then continue to push air out as much as you can. That amount of air that you pushed out would be expiratory reserve volume. The residual volume is the amount of air that remains in the lungs at all times. It's also the amount of air that's left in the lungs after a forced exhalation. Remember, we just talked about the expiratory reserve volume. Once you have exhaled that amount of air, you have the residual volume left in the lungs. This is approximately 1,300 milliliters in the average person. I'll tell you something that gave me the creeps when I was a student, and one of my teachers said that the residual volume of air is present in the lungs even after death. And I thought, ooh, even after death. And it's true. As an x-ray tech, I can tell you I've x-rayed many people, or some people, after they've passed away for various reasons. And sure enough, there's still air in those lungs. They have the residual volume there. I've seen x-rays of mummies, 2,000-year-old mummies, and they still have the residual volume of air in their lungs. If you'd skip vital capacity for a moment and look at functional residual capacity, this is the volume of air or amount of air left in the lungs following exhalation during normal breathing. So this time, just think about tidal breath, in 500 milliliters, out 500 milliliters. Once you've breathed out, you still have about 2,300 milliliters of air in the lungs. We're talking about the tidal volume or tidal expiration. 2,300 milliliters left. That amount of air is called the functional residual capacity. This is a very important entity because this represents the amount of air left in the lungs that's available between breaths. I'd like you to ponder that for just a moment. An average respiratory rate is from 12 to 20 respirations per minute. And a normal or an average heart rate, the normal range is from 60 to 100 heartbeats per minute. So let's say that we have an individual who is breathing 16 times a minute, and their heart rate is 80 heartbeats a minute. 16 respirations a minute, 80 heartbeats a minute. If you divide 80 by 16, you get 5. This means that for every one breath in and out, for that individual, blood rushed through those pulmonary capillaries 5 times. So that individual had 5 heartbeats for every breath. Between breaths, then, the blood goes through the capillaries 5 times. This means that there has to be enough air in those alveoli containing enough oxygen so that there's plenty of oxygen to move out of the alveoli into the capillaries right before the next breath, just like there was enough immediately following a breath. Hopefully this makes some sense to you, but basically if you only breathe 16 times a minute, then there's a significant amount of time that between the two breaths that breathing's not occurring, that blood is still circulating. There has to be plenty of oxygen to keep going into the blood as it's circulating through. That oxygen is contained within this functional residual capacity. Like I said, a very important concept. If you look back at vital capacity, which is the second bullet point, vital capacity is another important volume or capacity that is measured during pulmonary function tests. It's the maximum amount of air that can be exhaled following a maximum inhalation. So think about inhaling as big a breath as you can and then blowing all of that out. That's called your vital capacity. At the bottom we have total lung capacity. It's just what it sounds like. It's the total amount of air in the lungs following a maximal inhalation. So think of breathing in as much as you can and then measuring the amount of air that's in the lungs. For the average adult, that would be 5,800 milliliters. This graph illustrates the respiratory volumes and capacities. Don't look at the graph and go jump off a cliff or something. It's not as difficult as it looks at all. You know that a graph has an x-axis and a y-axis. On the x-axis of this graph we have time. So you can see, if you look at, before we even look at the y-axis, look at the tracing there. We have the little blue line going up and down, up and down, up and down. And you can count, I think it's 13 or 16 times, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Looks like 13 breaths that this individual took. This could be, where the blue line ends, that could represent 1 minute, basically, of time. Now look at on the y-axis, lung volume in milliliters. So we have from 1,000 up to 6,000 on the graph, with the total lung volume of this individual being slightly less than 6,000, and that's where the dotted line is. That's the person's total lung volume or capacity, about 5,800 milliliters. Okay, now notice we have some other dotted lines. I'd like you to look at the pair of dotted lines that are at levels of about 2,300 to 2,800 milliliters. So the two middle sets of dotted lines, I guess you could say. Notice that most of the upward and downward excursions of the blue traces lie within those two lines. What you're looking at then is every time the blue line goes up from 2,300 to 2,800, that's the tidal volume of air. 500 milliliters has moved into the lungs. You'll notice 2,300 to 2,800 is 500 milliliters. And then notice the tracing goes back down again. A downward motion means that air is moving out of the lungs. Upward motion means air is moving into the lungs. So in and out, in and out. 1, 2, 3. It looks like 1, 2, 3. 3 tidal breaths in and out. The fourth breath, the individual took in 500 milliliters of air, or the tidal volume of inspiration, and then they have breathed out not only the tidal volume, but they've breathed out even further until they can't force any more air out in. That's called the expiratory reserve volume, if you recall, the amount of air pushed out of the lungs following a tidal expiration. So if you look, that would be the fourth breath, and now the person's going to take the fifth breath. It's coming up from the line that's at about 1200 milliliters, and it's going back up to the 2800 milliliter again, and then you have another tidal breath, and then this time the individual breathes in as much as they can, the inspiratory reserve volume. That's that first great big peak, and then they breathe it out again, and then you have two tidal breaths. They do it again, they breathe in as much as they can, and now they're going to exhale maximally. And that's the 1, 2, 3, 4, 5, 6, 7, 8, 9. That's the 10th breath. It's the second large peak in the blue tracing. They've breathed in as much as they can. Now they've breathed out all they can. Notice that at the very bottom of that, where the upward deflection goes and now the downward deflection of that blue peak, notice that that dotted line, anything below that, or the volume below that, is the residual volume, about 12 or 1300 milliliters. Then the person breathes in again, and now they've got 2 or 3 more tidal breaths. So notice we have each of these labels: total lung capacity, residual volume, etc. All of these are labeled by the arrows. So I'd like for you to print off at least the previous 2 slides and this slide, and read each description and notice the corresponding tracing, so that it will really mean something to you. Now we get to the experimental part of this lab. The experimental part is the easiest part, and it's the shortest part. In this, you're going to determine your tidal volume. This procedure is for homework, and it's something that you can do at home. You just need some very simple materials, such as a 2-liter drink bottle that's empty without the cap. You need a sink of water, some plastic tubing, and a measuring cup, and that's basically it. So I'd like you to perform that. I have an experimental procedure listed also here on Moodle. I'd like you to follow those directions and report back to me during the next week, during that lab, and I hope to see you then.